Thank you, Pam. And for the Michael S. Gordon Lecture in Medical Education, we would like to invite Dr. Elizabeth Hunt. Dr. Betsy Hunt is the David and Marilyn M. Zemierovisk Director of the Johns Hopkins Medicine Simulation Center. Dr. Hunt was elected to the Delta Omega Honor Society at the Johns Hopkins Bloomberg School of Public Health, where completed a master's in public health and a PhD in clinical epidemiology. She is currently an attending pediatric intensivist in the Johns Hopkins Pediatric Intensive Care Unit and an associate professor in the Department of Anesthesiology and Critical Care Medicine and Pediatrics, and is chair on the Johns Hopkins CPR Advisory Committee. She is a founding member and senior co-chair of INSPIRE, the International Network of Simulation-Based Innovation, Research, and Education. Dr. Hunt, please.
Well, thank you. It's really an honor to be asked to speak when I think of Dr. Gordon and all the work that he's done, and Barry Eisenberg and that whole group. And I think that the conversation that we're going to have about translating our work from the educational field, hopefully into the clinical arena, they're certainly pioneers in this area, so what an opportunity for me. I was asked to think about talking about the context of my work and what I've done in terms of trying to use simulation and simulation research and education, and then make a connection with our actual theme of connections. And so you'll see that I was trying to think about this idea of what do we do in the lab and how do we make as big an impact as possible on actual clinical practice. And I think that's the holy grail. So many of us have been trying to figure out these large studies that show that we've saved patient lives, and this is important, and we should keep moving forward with that. But I think that there are tiny moments that are happening on a regular basis where each of us is making strides towards actually improving the care that we deliver towards patients. And my goal is to highlight how I have done that, and also hopefully give you some thoughts about that. But first I wanted to start with a historical context. And so I should mention my disclosures. I don't have any specific conflict of interest, but certainly some grant support. And there are a few things at the end that will show you that we have some patents pending on some innovations. So let's start. What are my objectives? So the first is to briefly describe the historical context of the translational impact of simulation education. And then the second is to actually give a few examples of simulation research where we identified targets to improve clinical adherence to best practices. And the third is to go through a series of innovations where, again, we're trying to impact the care that we deliver to patients. For those of you that don't know, I feel like I should give a little pretext. My passion in life is resuscitation. You'll hear a lot about resuscitation during my talk. I can't help it. And I specifically am interested in anything that's time sensitive. So if you have time to go look it up in a textbook or go to look online, to me that's certainly still important, but it's not what I'm obsessed with. I'm trying to figure out how to have our nurses, our physicians, our respiratory therapists, or even our parents be ready for an emergency, and how do we do everything we can to make sure in that moment they're able to perform the way they would want to, that they don't look back at that moment and regret what happened. And what tools can we give them to be as ready as possible? And so that's been my obsession. And so I have some colleagues that are equally obsessed to me. And we created a film a few years ago for the anniversary of the CPR, 50 years of CPR. And I had an opportunity to interview two of the pioneers in that area. And I wanted to share just a few minutes of that video with you. So if we're lucky, it'll play here. And so I hope you enjoy this clip. I think I first got this sense that Johns Hopkins was a really integral part of the history of resuscitation when I was at Duke. And I did one of my very first talks on the history of resuscitation, and I found a very clean copy of the article. It was very helpful for my talk. And then I came to Hopkins and I was giving another talk on the history of CPR and came here to the stacks, and this is what I found. This original copy of the Cowenhoven, Jude, and Knickerbocker paper, and this brings tears to my eyes. It's been handled so frequently, and you can clearly see that at Hopkins it's a really important part of our history.
Certainly the most impressive and important event was the publication of the paper in JAMA 50 years ago, showing that in patients for the first time, if you compress the chest in a regular, rhythmic way, you provide enough blood flow so that you can go get a defibrillator and ultimately defibrillate a patient with ventricular tachycardia or fibrillation and save their life.
The history of CPR really involves 5 key gentlemen, and that's Dr. Cowenhoven, who was a retired department chair of engineering, who started a lab in Dr. Blaylock's Department of Surgery. He had a young guy, Knickerbocker, working with him, and they were trying to discover how to defibrillate through the chest. And as they were becoming successful with this, they made this observation that pressing on the chest with these paddles may in fact raise the blood pressure.
When they put the paddles on, a guy noticed that there was an increase. He put the paddles on each side of the chest. He noticed that there was an increase in blood pressure.
And rather than just ignoring that, because that's not what they were funded to do, he was curious about that, and he followed up on that, and they started as a team to think about if pressing on the chest might actually perfuse the organs. And that led to this famous moment about the elevator story that I've discovered when I was talking to them, where Dr. Knickerbocker apparently was working in the lab one day, and this dog was not supposed to have a cardiac arrest at that moment, and it did. And they wanted to save the dog, but they knew they needed electricity, because that was the part of the research they did know. And they knew that they needed to apply the electricity within 5 minutes or the dog would die. And so he asked his colleague to press on the chest, what we now call chest compressions. He didn't know what it would do, but he said, just keep pressing, I'll be back. And he literally ran down the stairs from the 12th floor of what's now called Blaylock, and he went all the way down to 5.
Made my way down, hastened pretty fast down the stairwell, down to the heart station, got the defibrillator, rolled it to the elevator, pushed the button, and waited.
Anybody that knows the Blaylock elevators knows that you have to wait, and he did. And he doesn't know, but he thinks it was close to 20 minutes, and he finally gets upstairs, and they're still pressing on the chest. And really, the dog should not revive, because they've never had a dog live more than 6 minutes. And he applies the defibrillator, and the dog immediately revives, and the next day is completely back to himself. And that was their aha moment. It's not what their research was supposed to be, but they discovered that chest compressions perfuses the heart and can keep as he says, it slows the dying process and gives you a chance to get them back. So Dr. Jude, who was working down the hallway on some other research, started talking to him about this, and he was an actual physician who was able to translate this. He was able to take this lab work into the actual clinical environment and save lives clinically.
I think at the same time as we were doing this with the cardiac, the mouth-to-mouth resuscitation was being done at the Baltimore City hospitals by Peter Safar and Jim Ewan. That's why you have the pulmonary in CPR. Otherwise, it would just be CR.
There's a story that Fire Chief McMahon had been invited to the Peter Safar's lab and shown how to do mouth-to-mouth to patients in the real world who'd had, for instance, a drowning. And then he was also invited over to the cardiac arrest lab and shown this chest compression component, and we understand that they met, and that's how this concept of CPR came together. It's a classic story from Johns Hopkins. There are different people from anesthesia, from surgery, from engineering, all working together and coming up with this key concept of CPR and helping us save lives, and here we are 50 years later. So I hope you enjoyed that clip. These two gentlemen are certainly heroes of mine, and one of the things that strikes me about this, they were certainly scientists. They had laboratories, and they had funding, and they were very committed to this concept of defibrillation. But what I really liked was this element of curiosity that I think is really, really important to maintain as we try to figure out best practices in science and certainly in simulation. I think we're, unfortunately, in this healthcare economy, having to figure out the best way to apply our methods and the most efficient way, the most effective way. And so we have to maintain our curiosity in terms of whether we're making a difference or not. And I'm concerned that there have certainly been times where I've created a curriculum that the students love, because they do, they love it, right? And they feel good, and you've given them a simulation, and then they want to know what they did wrong, and they are so engaged with you about how it went, and then they left, and you feel good, and they feel good. And then I've done a series of studies that showed that I made zero impact on their subsequent behavior, and isn't that appalling? So, feeling good is, it's nice, but it's really probably not good enough. And that's one of the things that I've been trying to push myself again and again. My PhD thesis did show some differences that I made, but it also showed many things that I did that had no impact. And so I think we have to keep asking these questions. So when I show you this picture here, this is a real special item to me, and this is Drs. Knickerbocker and Jude performing CPR with me on the opening of our Sim Center. And I've learned so much from them, but what was really interesting was, in addition to talking to them, I had an opportunity to go into the archives and read paper after paper after paper from random folders about their work. But specifically, what I found almost more interesting than the scientific protocols was what they did after they discovered that chest compressions can perfuse the myocardium and keep a heart and a brain alive for X number of minutes. And so what you'll see is a series of letters that people have written to either these scientists or to Dr. Blaylock, who was their mentor and funder within the Department of Surgery. And what we found is that they apparently published lay articles in Reader's Digest. And when I say Reader's Digest, not just the American version, but I found letters from Sydney and from Vienna and from various places all over the world where they essentially were saying, I'm fascinated by this concept. I've had a man drop in front of me in my market in Harlem, and I'm very concerned it could happen again, and could you come train our fire brigade? Or a series of studies like this, physicians and operating theaters in European countries who were saying, we're very interested in what you're doing. Could you send us some information? And they knew that they were overwhelmed for a number of reasons. They weren't education specialists, but they also, certainly as much as they would love to travel, couldn't go to all these places. And I just thought it was fascinating that not just their JAMA article, but also their lay article was essentially making a really big impact. Think about it. We've all heard about chest compressions. There's the breath of life in the Bible, and there's other places where chest compressions have certainly been referred to. But what they did differently, and I think this is important for us to think about, was they looked at how to truly have an impact, not just to write an article and move on to the next topic, but they thought about, what can I do that will really make it catch fire? And so since we're at a conference, I thought it was interesting to share this story. This is a Guy Knickerbocker who came back a couple years ago to hand over an award that the three of them had won. This is Drs. Cowenhoven, Knickerbocker, and Jude, shortly after the JAMA publication. And they had gone to the American Medical Association meeting, and they did an educational exhibition. And what they did was they created a half-body mannequin. They then, it's very interesting, had cine films of a rhythm strip, of a cardiac rhythm strip. And apparently, Dr. Knickerbocker had done some engineering where they could either have it be normal sinus rhythm going by, or it could be VTAC going by. As far as I know, this might be one of the first arrhythmia generators. It was switching the film in and out. And apparently, every day that they were at the conference, it was 5 days in a row, the film would get sort of chewed up and eaten up a little bit and dirty and wouldn't show as well. And that night, they'd go home and clean the film and hang it and dry it and bring it in the next day. And during this, they actually had physicians do chest compressions once they saw the lethal rhythm, and then practice defibrillation At that point, they couldn't actually deliver the energy, so they didn't have the safe way that we do of practicing simulation, practicing compressions. But this, to me, was this, I'd never heard of this story, and I thought this was amazing. And when he brought this award to donate it back to Johns Hopkins for the archives, we also got the little device, to switch the films that he'd created. And to me, it's one of, again, I think it's history. I think it's one of the first arrhythmia generators. And one of the things that I want us to think about this moment was that they not only discovered chest compressions, hello, this is highly important, but then they really were forward thinking about how will we, as scientists, actually engage other physicians and medical practitioners and lay people on how to spread this. So they did peer review publications, they also did educational innovations, and then they networked with their community leaders. I think of the Newborn movie, the most recent one, where Rachel Weisz used the term conferencing. I hadn't heard that term before. She was frustrated because she didn't get to conference anymore. And so I think that's what we're all doing here today. We're conferencing, and I think it's really important that we're sharing our innovations with each other, and hopefully they spread like wildfire when we find something that works. So what I wanted to do now was to shift gears into some of the observations that I've made over time and essentially share just very briefly little bits and pieces from each of my studies. And I'm hoping they'll both, if you are clinicians, they'll inspire you to think maybe how to teach just a little bit differently, but also just that the theme of being continuously curious, of following through on how to spread your work beyond your own population. So I start with this slide. And I, especially the pediatricians in the house, I challenge you for a second to think of what clinical entity might this represent. Probably the people that work with me most might know what I'm talking about here, but to me, the little kitty on the right that's just hanging on and is just, he's there, but this is compensated shock. This is when I walk in and I see a child whose heart rate is just pounding, and in fact, their blood pressure might actually be up, and their body's doing everything they can to hang on, and they haven't fallen apart yet, right? And if you're a novice clinician, you don't recognize that this child is actually teetering on the edge of death. You might actually think they look fine, and something that I'll see is I'll walk down the ICU and I'll hear someone say, "God, that kid's a brat," and I'll literally turn around and walk back over, because a brat could be the sign of not enough oxygen to the brain. And these are the kinds of signs that, how do we teach that? This is subtle, right? And then this other is the decompensated shock. This is when they finally just don't have enough anymore. And the thing that I love about pediatrics, and it's true to some extent with some adults, but is, if you give that flower some water, it'll perk right back up, right? So if we resuscitate exquisitely in the next 5 minutes or in the next hour, the chance of that flower coming back, at least for a while, is pretty high. But if the longer you take to go look things up in textbook or to go see another patient instead or any of these other things, your chances of getting this flower back or this child back are slipping away. And that's really hard to teach, right? Recognizing the child, but then that you have to act now. And sometimes you do have too many things on your plate, so how do you help somebody understand, I have too many things on my plate, but this child's about to die, so I have to reorganize my list, or I need to call for help. Calling for help is like one of the most important things that we have to learn how to teach our folks to do. So time dependence. If you look at the pediatric shock guidelines, much like the adults, they're very goal-oriented. But a lot of what we talk about is what do you have to do in the first 5 minutes and then the next 5 minutes, et cetera. And it reminds me a lot of these pictures that a lot of us have of these NASCAR and Grand Prix pit crews. And one of the things I think is interesting about the statement here, it says, the job in the pits is one of the most pressured in Formula One. A pit stop is studied choreography, and only the best are good enough to ensure comprehensive service for the driver. I mean, it makes you realize they are chosen, and they practice, and this is like hardcore. And it's distressing to me that they practice, for instance, it says, every individual role is practiced thousands of times and must be carried out perfectly. They practice this way more than we do to resuscitate a child. I mean, how is that possible? And so, as we try to figure out what's cost efficient and where we should spend our time and where we should spend our money, I think, this is the cost the cost of a lost life is really hard to put money on. But this is important for us to think about what can we do to make ourselves excellent like they do. So important issues to consider. So I understand that we all have different areas of simulation, and in fact, I want to make sure that it's clear to you that I think it's equally important to practice how to deliver bad news. When I think of when I have to do that on a Monday morning and walk in to someone I've never met before and tell them their child's going to die that day, you can imagine that that's the memory that they'll have for the rest of their life. And if I do that poorly, I think that almost has as big of an impact as if I'm able to resuscitate a child well or not. And so I definitely think that's important, but again, my focus personally has been on things that are times of the essence, where failure equals life-threatening, and where we can't afford to let people fail. And so I was thinking about what Dr. Klein said yesterday about it's not just ensuring competency, but really excellence, and how do we strive for excellence. And some of you have seen my talks on this way of teaching that we're trying to promote in certain instances that we call rapid cycle deliberate practice. But one of the things that I think is really important is that we can't just teach them which is what I think I was doing in my original simulations. I would let them do a simulation, and they'd be really engaged, and then we would talk for 20 minutes about how did that feel, and what did you do, what will you do differently, and let me give you some tips, and then they would walk out feeling, yeah. And then I would study them later, and they weren't any better. They weren't. And what I realize is for what I'm teaching, that I really need them to have multiple opportunities to try again, so that at the end of a 2-hour period, I know when they leave, I actually know they're better than when they came in. Can I say they're perfect? No, of course not. Can I say that they're actually going to translate it that day into the environment? No, but I think I can say I've increased their chances. And so what I talk about is different tricks of repetition, muscle memory, pattern recognition. We're doing a lot of scripts these days, helping them find the words of, just to say, I'm sorry, guys, I'm confused. Who's the leader? It's interesting how just teaching someone to say that. We recently had a simulation that Robbie and I did at a hospital in our community where a nurse was trying to manage a patient, and she was drawing up drugs and she was having problems, and this new pharmacist who'd never actually played the role of drawing up drugs in a code. And so she's very, very nervous. So here she is taking over for the nurse to draw up the drugs. And she remembers that we've told them that they have 4 questions they're supposed to ask. The pharmacists have 4 questions that they've been scripted to ask. And she's very nervous, and she finally says to the leader, excuse me, and he can tell that there's something that someone wants to say. And he turns to her, and he's trying to be patient. And it's very clear that he's not actually being patient. And he's like, and she says, I'm sorry, what algorithm are you in? And he looks at the monitor and he says, we're in VFib, can you get the defibrillator? So all of a sudden, this plastic child, who was in this lethal rhythm and had been for 5-6 minutes, had not been recognized, this pharmacist, by stating her script, unstuck the whole team. And this was pretty exciting, right? And all of a sudden, in this simulated environment, she learned how important she is, and hopefully is empowered to speak up next time, and he learned to actually be patient with her. So that was good. So what I'm going to do now is zip through several studies. Many of you have heard me present these before, but not everyone. And I just want to talk about what are the key messages that I learned. So in this first one, this is a long time ago now, we went to about 1/3 of all North Carolina emergency departments. And we had a child who had fallen off the slide. It was a plastic child who was having mental status changes and was brought into the emergency department. And then we measured what they did. And what we noticed were things like 49% of them were not able to estimate the child's weight quickly. And as you know, and many of you know, you have to treat a child based on their weight. And in terms of quickly giving them fluid, which remember we talked about the wilting flower and how do you perk them up, the intraosseous is the key to that. And in fact, 70% of them had problems doing that quickly. In terms of ordering the fluid bolus quickly, almost 90% of them had problems with that. And then dextrose, this is a real problem with wilting in children. We have high metabolic rates and they burn through their glucose. So hypoglycemia is a much bigger deal in children than it is in adults. And essentially 1 or 2 programs thought to check the dextrose in this emergency setting. And so these were targets for us. And then we looked at the best versus those that were challenged, and essentially looked at the top programs versus the ones that weren't performing well. And we noticed that these basic things like putting on oxygen, you can see it was 86% versus 13%, or things like quickly estimating the weight of the child, 71 versus 13%. And even preparing for CAT scan, which is something that when you go to do a procedure, you don't want to be rolling, have a child deteriorate and not have all your equipment. The best of the best, 100% of them, absolutely. Of course you would prepare before you roll a patient. And then we noticed that the hospitals that were struggling, who were not methodical, they'd say, oh, we got to get to CAT scan, and they would roll. And they wouldn't have any of the equipment that one would need if the child deteriorated. So just by doing this for me is how I use simulation as a probe to figure out what are the things that they're doing poorly that we need to target. So this concept of fluid resuscitation, for years we would put fluid on the pump. And I'm just going to do a little math for you guys. So our guidelines tell us that we need to give 20 cc's per kilo in the first 5 minutes. And if a child is 20 kilos, that's 400 cc's. So we have to give 400 cc's of fluid in 5 minutes. So you can imagine in a 20-kilo child, in 15 minutes, we need to give 1.2 liters, okay? And that pump can go, the fastest it can go is 999. So you will give this 1.2 liters over a little over an hour rather than 15 minutes. So if you ever hang the fluid bolus of a child this size on this pump, you will fail. Now, you could succeed by putting in 3 IVs and have 3 pumps, but people don't necessarily remember to do that. So this is not an option. We have to teach people. And then we've come up with some tricks of how do you grab syringes and start pushing some fluid while you're figuring out your other mechanism. And then we've all come up with different solutions for this. But one of the things that I wanted to say in regards to simulation, and again, I'm thinking of my team and how they know that one of my requirements for every simulation is, have we hooked up the mannequin such that when they really push fluid, you can collect whatever they've done? What I can tell you is that for years, the simulations that I participated in as a student and then that I perpetuated as a faculty was that we would say, okay, fluid bolus is in. And then they would say, okay, I'd like another 20 per kilo. And we'd say, okay, the fluid bolus is in. And then the students are learning that it's that easy, right? And as a transport physician, that's where it really came home to me. Because I would speak to the physician on the line, and they say, we have a child in shock, decompensated shock, I'm fluid resuscitating, and we need you to come pick up the child. And I'd say, how much fluid have you given? And they'd say, 60 per kilo. I'd say, great, can I talk to your nurse? And then I'd get on the phone with the nurse, and I'd say, so how much fluid have you given? And she'd say, I'm not really sure yet, let me get back to you. And a minute later, she'd come back and she'd say, 400 cc's. And we'd do the math, and that would be 13 per kilo. So there was a complete disconnect between what the physician had ordered and what the nurse had administered. Now, often the nurse knew that she was going to do 60 per kilo, and she would do that when she could. But that had not been communicated back to the physician, that even as I'm ordering my 3rd bolus, I haven't even finished the 1st bolus. And so one of the things that's been really interesting is for a long time, when we had people push fluid through these mannequins, we only had 1 liter bag to collect the fluid. And remember, I just told you that 15 minutes, that shouldn't be enough. We should get to 1.2 liters. We should overflow the bag. We should make a mess in our simulation. And I never had to worry until recently to hook up a 2nd liter bag, because no one could successfully achieve 60 per kilo in 15 minutes. Now, this really shouldn't be this hard, but it actually is. And so now we do things like fluid resuscitation Olympics and, which way's faster and how do you communicate? And this is all partial task. And once they know how to do it, then we put them in more immersive sims. But these are the kinds of things that I think get back to translational science. We assume these things are happening because someone passes a test and can communicate to us that they know the algorithm, and they even can tell us that they know how to hook up the fluid, et cetera. But yet, again and again and again, when you review from a sentinel event, which I'm frequently asked to do at other hospitals, children are not receiving the care that the guidelines are asking us to, and nor are adults in many cases. So this time-sensitive component, what do you have to do by 15 minutes, 20 minutes? I think, in my mind, the more that we let people know what the goals are, and frankly, how they're failing. There's that gentle way of telling them, but being frank, that no, you did not. Let's try it again. Let's try a different strategy. But if we walk out saying, us not knowing, we don't know that they didn't achieve it, and we're happy that they maybe used closed loop communication and they followed the algorithms and they asked for the right things and they were doing everything right, but we didn't actually measure what they delivered during the simulation and we didn't actually give them feedback on it, that's where I think sometimes we miss the mark. And then we don't give them an opportunity to take what we just said and try again. And so I'm really fascinated with how can we as a community keep working on pushing ourselves further to make sure that what we're teaching is actually being received. And of course we need to study, is it getting to the actual patient in the clinical environment? But I think frequently we haven't actually measured if they're getting it even in the simulated environment yet. So here's another study we did, and this was where I was in the middle of my MPH. I just went around and observed mock code after mock code, a number of children's hospitals, one a month. And these programs had been in place for decades. And we do in situ programs, I think we do them because we think they make a difference. We do them because we feel really good, about the fact that people walk in and they get an opportunity to practice as a team, and then we debrief them, and they walk out with the high fives, and we all feel really good. And then we measure their performance, and we see in this particular study, out of this group of 15, only about a quarter of them started compressions within a minute. We use a standard now of 10 seconds, so I don't think anybody would have passed at that point. But this highlighted to me that our decade-long in situ program was fun, but I'm not sure that it was actually saving any lives. So then we started working on, well, how will I measure individual residents to see how they're performing and try to figure out what they talk about are variables that can be changed. So I can't change your ethnicity or your weight or your gender quickly, but I can potentially change, yeah, we all know that. I can try to change certain elements, and I have to figure out what those are. Modifiable risk factors, we call them in the epi world. And so this is just a Kaplan-Meier curve that shows, if you look at the blue line, you'll see that and when I say 3 minutes there, I'm referring to 180 seconds, this is kind of the old terminology, that there was a higher likelihood that those who had ever defibrillated a mannequin or a human would shock a patient within 180 seconds, a simulated patient, than those who'd never actually gotten to do all the steps. And unfortunately, I imagine a lot of you have taken a PALS class or an ACLS class where the person at the head of the bed running the VFib algorithm gets credit for essentially successfully being involved in a shockable rhythm, but yet they've never actually touched the buttons on the defibrillator. And this shows us that people who touch the buttons on the defibrillator and operate all of the steps are 87% faster than the people who tell someone else to do it and don't actually touch the buttons. So to me, that meant that hands-on practice with defibrillation matters, and that changed how I teach. Then we started measuring their performance, and you can see in this first column that, for instance, had they started compressions within 30 seconds, that was my standard, it went from a minute down to 30 seconds. Again, we're down to 10 seconds now. But in this group, they started compressions at 100 seconds, and that was almost a minute and a half, and so they got a big red, and they did some other things not so well. So we gave them feedback, but then we gave them an opportunity to play again. And on round number 2, they started compressions within 16 seconds, and they did some other things faster, and you can imagine that some people really need a round number 3. And so this was when we started essentially figuring out that we need to allow multiple opportunities for them to incorporate the feedback. And frequently they're worse on the second time. They're in their head about everything you just said. So it's not uncommon that you need three tries. So hands-on defibrillation matters, and you need to let them try again. And so this is a more sophisticated feedback that we have these days from our actual defibrillator that measures, and you can see here that none of their compressions are in the green zone, which is the target, deep enough, and this guy finally gets up there. But now we're going from some of these checklists where I had to sit and stare at them to these devices that help me capture data. But during these, we implemented a curriculum that we call Rapid Cycle Deliberate Practice. I know some of you have heard about it. And we looked at the impact of that. And we saw over a 3-year period that period of time between when you say clear and actually deliver a shock. That's called pre-shock pause. Went from 84 seconds down to 8 seconds. And this is important because we know that if it's longer than 10 seconds, it impacts your chance of survival. And we also know they're down to 3 seconds now. We can do better than what we were doing then. But by testing them again and again and again, we were able to show that we could impact their performance. We also, on here, you could see that this curriculum was associated with a 1.65 times, so 65% higher chance of shocking within the appropriate time. And I also point out the PGY3 at the bottom, the 2.8. For the first time, we were showing that our third-year residents were actually faster than our first-year residents. Prior to that, we proved systematically that our entire residency did nothing in terms of, I'm sure they learned a lot of other things. But in terms of actually saving lives, not so much. So there were some key elements that we found with rapid cycle deliberate practice, and those were, we wanted to give them multiple opportunities to do it again. We wanted to give them explicit choreography. If you stand here, you're going to see it faster. We wanted to show them the right way and to actually give them a gold standard. And ultimately, if they figure out an even better right way, fantastic. But today, I'm teaching you my way. And then we would actually interrupt them, or as Jenny Rudolph has advised me to say, we would pause and rewind, and we would have them try it again. And then ultimately what we were trying to do is get over learning. They did it more times correctly than they did the wrong way. I want to thank Julianne Peretta and a number of people, Walter Epic and others, who've really helped me, since I do not have a master's or PhD in educational theory. They've really helped me think about how to frame this in a way that I can help share it with you guys. So then moving on, when we watched these mock codes, one of the things that we noticed, it was just shocking to me the day that I finally noticed this, was that this person would say, "There's no pulse, get me epinephrine. There's no pulse, call the code team," rather than "there's no pulse, I'm starting compressions." So here they notice that there's no pulse, yet the clock's ticking by. And so we quantified that, and then we looked at, if you say it the way I would want you to, are you faster? And the fact was yes. If you say there's no pulse, I'm starting compressions, you started compressions within 30 seconds, versus this mean of 150 seconds in the rest of the group. And so we call this action-linked phrases. There's no pulse, I'm starting compressions. That's VFib, I'm starting compressions, get the defibrillator. And these are action-linked phrases, again, associated with better performance. And we've been working with Lisa Sins to try to show others the hopeful impact of this. And we would love it if some of you would want to explore this more. The next thing we did was we targeted my frustration with our curriculum of teaching CPR on your knees for whether it be 30 minutes or 4 hours, and then expecting those people to then understand how you would do CPR with a step stool and a backboard, and that you would miraculously figure out this much more complex situation. And why not just teach BLS in the hospital setting? So we did a randomized control trial comparing medical students who learned it the traditional way versus our way, where yes, you still learn a little time on your knees just in case somebody at the airport drops, but we spend most of the time teaching you how to manage an in-hospital arrest. And I'm not going to show you all the results, but we looked at, for our out-of-hospital scenario, because we did an out-of-hospital and in-hospital assessment, that they were quicker to start compressions if they'd been through our curriculum, and that their time off the chest was shorter. And then we looked at some real basic things like, would they know to use a backboard intuitively? And the answer is no. In the traditional course, they only thought about doing that 17% of the time versus 70% who took our curriculum. Shows you our curriculum wasn't perfect. It's better now. And then the step stool, same thing. 93% in our group thought, I better use a step stool to get up and get the leverage I need to do good compressions. But intuitively, only 28% of the traditional group said, can you get me something that I can stand on? And so these are things that have to be taught if we expect people to do them well. And this gets back to this idea of intense data-driven and contextually relevant training makes a difference. So this is Pam and Dr. Jeffries, our president, and myself, and one of our mentees, Nancy Sullivan. And she had just defended her doctoral thesis, and she did this fantastic project She did hundreds and hundreds of simulations where someone was either randomized to do training every 2 months, every 3 months, every 6 months, or every 2 years for CPR. And it was a really nice decay study that I hope you guys will get to see soon. And the idea was about not the compression quality, which I know people have been studying, but more this idea of how quickly can you get on the chest and how well do you work as a team for this in-hospital choreography. So that we wanted them to start compressions within 10 seconds, defibrillate within 180 seconds, minimize no-flow fractions. And so what you'll see here is just one little graph that gives you a snippet of it where you can see that if we said they had to start compressions within 10 seconds, the control group was never ever going to make that. And even our core group, the every 2 months, only did it a third of the time. But even if you're liberal and say they don't have to start compressions for 20 seconds, there's this very clear decay curve. And I think at the end of the day, what's neat is that this is consistent with the RQI program that American Heart's putting out based on the work from CHOP, that every quarter we probably need to refresh our skills. We can't wait 2 years. And so to me, I think what I'm saying is that simulation as this translational tool again can be used to define how quickly our skills decay and then help us figure out how frequently we need to retrain. I'm just going to show here a little snippet here of our institutional card that we hand out for helping us with resuscitation, a cognitive aid. And this is our most recent version. And you'll see at the top it says cardiopulmonary rest, highest priorities, high quality CPR and rapid defibrillation. And we tried to include in it things that people are asking for a checklist. You know, what do you, okay, you had to push hard. Well, what, how hard, how fast? And then even on, there's more sophisticated things. If you have an arterial line, your diastolic pressure, what should it be greater than 30? I'm not saying that this is perfect, but what I can tell you is that all of our previous studies where people pulled out their card, what was distressing was we would see people who would say, there's no pulse, and instead of starting compressions, they'd pull out their card. Okay, now, this is a bummer. You know, you wish that they would know there's no pulse, I'm starting compressions. But hey, they've gone for the resource, and if the resource tells them what to do, fantastic. And what we saw is only in a minority did then looking at the card make them go, oh, I better start compressions. Instead, and if you look at these cards, many of them said, consider CPR. And it's under the pulse list section, so I find that distressing. And so, this is one of the reasons that we write it again and again, highest priorities, high quality CPR, and you're just seeing the top of the other algorithms. So for VFib, VTech, the first thing at the top is immediate high quality CPR. So we're trying to hit it home again, that you gotta do high quality CPR and then move into this. And so simulation can help us design better cognitive aids. So another thing that we're doing now is that every week, we have a really, really intense program of trying to identify all our cardiac arrests, and then every week we review any cardiac arrest that happened in the preceding week, and then we try to say what went well, what went poorly, and we collect data from the defibrillator, and we do all these things. But one of the things we started realizing again and again, so for instance, we had one child, I'm just going to admit this is very distressing to me, who was going on to ECMO and who went into VFib, an 8-hour-old went into VFib in front of everybody. And they were doing an echo, and they knew it right away. And they started CPR immediately, and they knew they needed a shock. And they were excited because they already had the pads on, and they were ready to go, but it wouldn't work. And what was really interesting was a series of things that we found out. Number one, the defibrillator pads actually weren't really on the baby anymore because the surgeons had said, oh, well, we need to put the Bovie pad there, and we need to put the echo probe there. But they hadn't communicated to the rest of the team, we're just going to move those off. And in the meantime, the defibrillator had made its way back, and here's a diagram. Here's a room diagram, in case you're wondering how many people. That's about 35 people. And the Zoll had made its way back to the back of the room. It was connected to the pads and up towards the baby. But at that point, there was no mental model that the defibrillator, because you know it's an infant, it's an 8-hour-old, they're not going to be shocked. We'll have it in the room just in case. That this was an integral piece of equipment, and especially this day and age with the FDA proving that these pads now tell us, the defibrillator now tells us how deep you're pressing, you know, et cetera, et cetera. So it is we call it needs a place at the table. It's an incredibly important piece of equipment. And so here you can see another diagram where in red, the Zoll is across from the compressor because that's where it has to be. So every single cardiac arrest, we do a room map. Where were you standing? Where was the leader? Where was the coach? Where was the equipment? And we're learning a lot. And then when somebody says, there's no way that I could have gotten it to the other side. Really? So then we go into that actual room or one of the other ICU rooms, and we replay it, and we do the simulation until we figure out a strategy that next time they can use to figure out how to say to the parents or to the nurse, okay, keep doing compressions while I figure this out, but my goal is to get the Zoll to the other side of the bed. So how do we flip things around? And simulation has been this amazing tool for us to practice different strategies. So then, how do we know what to teach in the simulation laboratory? And I think this gets back to me, I use these simulations and I observe these patterns of errors, but I also look for gaps, like I just did in the clinical environment. And these gaps represent deficiencies in our current curricula or in our current equipment design. And then this helps me formulate what am I going to teach. So my teaching is very, it's evolving, it's not static, and I'm hoping that that's true of you as well. So looking again, I flipped through this briefly, but there's this rich and sophisticated types of material now that we can use to capture data and the real environment. So this is the first time now, I'm just going to flip through a couple of slides here. This is a rhythm strip that I would have gotten in the past. The baby had a cardiac arrest last night, and I'm asking what was the rhythm. They're like, PEA. That doesn't make me really feel convinced that it was PEA. And then sometimes people have been asking me, how do I know when they started compressions? Well, it's awesome, and I imagine a lot of you are doing the same thing when we can pull hemodynamic data. And so what you can see here, for those of you that aren't familiar with this is a rhythm strip where the heart is beating slower and slower and slower, but yet there was an arterial blood pressure that was okay, and then finally the blood pressure goes away. So now we're bradycardic, but we actually are pulseless, so we are going to call this PEA. But what's really neat is then you can see, yep, that's when they started the compressions right there. So if we can pull that, we can figure out exactly when time 0 was for the pulse being lost and exactly when they started compressions. And here's another example where you're able to see what's going on here, and yep, that's where they started compressions, and the arterial line is responding to that. So I actually want to give some credit to Julie Campbell and Jordan Duvall, who are my partners in crime in the Hartwell lab, where we've been trying to figure out what we see in that awesome ICU environment. How do we bring that into the simulation lab, both for it to be our research lab and our education lab? So there's some simple things. So for instance, here's a time where they put the pads on, and they put it in our AP, our preferred presentation here. And what you can see is that the defibrillator up here is actually hooked up to the arrhythmia generator. So it'll work during this training game, but the cable's just hanging out there. And to me, this is massive negative learning. We know there's all sorts of people that have not figured out how those cables work. And they don't know where they go together. And if we let this go in training, which we did on this particular, you can imagine often do, that's not okay. So one of the things that we've been working on, and again, just full disclosure, we're, filed some patents on these things, but it's more to how do we figure out if someone is going to do pads the proper way, how can it be properly hooked up to the defibrillator? So you're doing all the steps. Remember I told you that my PhD thesis told me you are 87% faster at defibrillating if you've done all the steps before. So I need to make them do all the steps. This is an infant, and this is a low-fidelity mannequin. It could be a bag of rice, where this is really exciting for us, for our colleagues in Malaysia and some of these other countries that really do want to train for resuscitation. Maybe they do have one defibrillator in their hospital, but they've never actually gotten to practice on how to use it because they don't have high-fidelity simulators. Or they have an arrhythmia generator, but then they're not learning how to actually hook things up correctly. And so you can see this pretty unsophisticated, we call Peppermint Baby. Has this belt that allows you to actually hook up the defibrillator, and you see all the items on the defibrillator you normally would. The last thing I'm going to say, and then I'm going to be wrapping up here, is this end-tidal CO2 is a measurement that we use in resuscitation now to measure cardiac output, and it's basically a manometer of are you doing a good job or not, especially if you don't have an arterial line. And this is much lower cost, and some hospitals only have one. When I go to Cuba, they have one, and if there's an arrest, we take it to the place of an arrest. But even with only having one, they can make a difference and use this in their program. But this fancy defibrillator that we use in our hospital could never have end-tidal CO2 on it because the mannequins and the defibrillators don't talk. And so I was training them to look at this other monitor, which was actually translating back to the unit. And so if I want them to always have entitle on the Zoll, then I have to have it there in the training environment. And so that's what our team has done, is created it so that, for instance, if you have one of the SimManner 3G or SimBaby, it pushes it to the defibrillator. And you can see here, SimBaby actually has the belt and entitle CO2. You can see here that normally there would only be a rhythm strip, but on this one over here, they also get to have all the parameters of quality CPR, how deep is it, et cetera. So for my last slide, I wanted to just talk about how important the work we do is, but sometimes I don't think we truly look to see if we're making the difference we think we are. And I'm hoping that you guys all say, yes, we do, Betsy, you just haven't heard about it. So that would be fantastic. But I know that I sometimes slip into thinking that, teaching that day was enough. But I want you to try to find what is your metric of success, and did they achieve it? And ideally, did they achieve it that day? You can have your did they maintain it, but did they get better that day? And then, ideally, you'll know also what the decay is. And so I want you to maintain curiosity about best practices. For instance, where should the Zoll be? Where should the leader stand? I want you to avoid being stagnant in your curriculum. I'm hoping that you'll help me make systematic observations of errors, this Curious George concept. Keep watching, and have aha moments. Develop and test hypotheses, and try to measure the impact of your interventions. And if, like me, you figured out that your lectures on defibrillation are completely useless, then get rid of them. Spend your time doing something else. The shortcuts in simulation can equate to negative learning. So when we would let them say, the bolus is in, I don't think we fully understood the unintended consequences of that. So remember, I want you to help then think of innovations that can help us teach the proper way, all of the steps to do things. And then finally, I ask you to commit to excellence and maintain vigilance. I really, really appreciate you listening. I think I've gone not too far over, but this has been a really neat opportunity for me. And I think, again, of Dr. Gordon and all the work that he has done with Harvey and how that's impacted so many people. And it's a real honor for me to have this opportunity. So thank you.
Well, thank you, Betsy, for the brilliant talk. I hope you enjoy it, and enjoy the rest of your day. Make connections and have fun. Thank you. Thank you. Thank you very much.